Hello, my name is Dr. David Reggiani. I'm a dentist in general practice in Ortonville, Michigan. I'm also a founding member, fellow, and immediate past president of the International Academy of Oral Medicine and Toxicology. I'd like to take a few moments to explain our organization and to explain what this video is all about. In October 1984, a group of 13 health professionals met in Banff, Alberta, Canada, to form the International Academy of Oral Medicine and Toxicology, or IAOMT. Our objective was, and still is, to investigate the biocompatibility of dental materials. Further, we wish to promote the informed use of those materials found to be biologically acceptable. Other objectives included: 1. To accumulate and disseminate scientific information. 2. To stimulate and promote relevant research and education. Thirdly, to undertake relevant advisory and consultative roles. Fourthly, to attract and provide funding for relevant research. 5. To investigate scientifically sound complementary therapies. And lastly, to promote education. Dental school curriculum and research have always emphasized dental materials in regard to their mechanical and physical properties, such as durability, wear resistance, shearing and tensile strength, malleability, and ductility, to name a few parameters. No emphasis has been placed on the biological aspects dealing with toxicology, immunology, and ecological consequences of these substances inside the mouth and the rest of the body. In oral toxicology, our main thrust has been in the area of mercury exposure from mercury silver amalgam. Even though chronic exposure to mercury from dental amalgam has been long acknowledged, formal investigation of its potential adverse effects have been long overlooked until recently. Examples of other toxic materials include depleted uranium in dental porcelain, nickel beryllium crown and bridge alloy, and chrome cobalt prosthetic alloys. In the area of oral medicine, the Academy has encouraged research in the role of amoeba in the development and progression of periodontal disease, the occurrence of osseous defects in relation to oral and root canal therapy, and the influence of vagrant electrical currents generated by dissimilar metals placed in the oral cavity. It is the purpose of this video to do just that, to introduce you to this information that we know in regards to these subjects and to stimulate interest in this widely untouched aspects of healthcare.
Dr. Murray Vimy is an associate clinical professor at the University of Calgary School of Medicine, an international lecturer, and one of the leading world researchers on dental amalgam and its adverse physiological effects.
Silver dental fillings have been used for well over 150 years in North America and in Europe, and were developed by a British chemist by the name of Bell in around 1812. The material is 50% mercury mixed with silver, tin, copper, and zinc, and when it's put into your tooth it forms a hard mass and fills a cavity which the dentist has prepared in the tooth. Originally, dental amalgam came to North America with two brothers, the Crocor brothers, who brought the material to the New York area. These two brothers practiced dentistry, although they were never trained formally to practice dentistry. And there ensued in the early 1800s a debate with regards to the safety of this material. The then licensing body, the North American Society of Dental Surgeons, banned the use of this material and requested that the members of the society sign an oath not to use it. But because it was user-friendly, inexpensive, many more people could be helped, supposedly, with the use of this material, and dental amalgam became a very prominent material used in dentistry. Dentists refused to sign the oath of the North American Society of Dental Surgeons. It was forced to disband, and in its place arose today's modern American Dental Association, founded by the advocates of the use of dental amalgam. And it's interesting that today, 150 some odd years later, the American Dental Association views dentists who recommend the removal of mercury-containing fillings as being unethical, whereas their forebears in the early 1800s viewed the placement of dental amalgam restorations as unethical. Dentistry also was turned in from a cottage industry to a multi-billion-dollar industry because of dental amalgam. It made dentistry more accessible to people. And it's very important to have some understanding of mercury and the reason why mercury is so toxic. Mercury falls into the category of materials we call heavy metal, such as lead, that what used to be in gasoline, arsenic, and bismuth. And mercury is very toxic to cells and can cause much damage, partly because of its rapid ability to enter the body. As shown in the picture here, if you take lead and mercury of an equal weight, you would see that they share many common characteristics with regards to their molecular weights, with regards to their dentistry. What they differ in is in terms of their melting point. Everybody knows that mercury at room temperature is a liquid, and it's the only metal that has that property, be liquid at room temperature. Moreover, any small change in temperature causes mercury to vaporize. For example, here we have an equal amount of mercury and lead sitting on a tabletop for 1 to 3 days at 22 degrees centigrade. What happens is nothing really happens to the lead, but the mercury gives off vapor that's odorless, colorless, and tasteless. This vapor can be inhaled, get into the bloodstream, and rapidly diffuse to tissues in the body. Similarly, if we took the same weight of mercury sitting on the tabletop and the same weight of lead for 1 hour to probably about 10 minutes at 100 degrees centigrade, one would find that there would be no change in the lead. However, almost all the mercury will have vaporized. It's this property of being readily able to vaporize into a gas form that makes mercury one of the most toxic of the heavy metals. Mercury is also very dangerous to cells. It's very dangerous to cells because it's rapidly taken up, and because it's lipid soluble, gets into cells extremely easily. Once in the cell, it can attach to enzymes, the biochemical machinery inside your cell that operates your physiology, that produces energy for you, that maintains life. And the mercury, when it's in the cell, attaches to these enzymes and causes toxicity, causes the biochemistry of your cells to not be proper, to not function properly, to not create a proper amount of energy. In the human body, and indeed in any animal body, the two main sites of damage for mercury vapor happen to be the central nervous system, in other words the brain and your nerves, and kidney. These two areas have been identified as being key areas of toxicity with regards to mercury. But it should be understood that mercury can affect all cells and all tissues of the body. It's just that the brain and the kidney happen to be the primary sites of such deposition. There is, however, international scientific agreement on many facets with regards to this issue. It is scientifically agreed that mercury is a highly unstable and volatile metal. It's also scientifically agreed that the major source of human exposure to mercury in the general population is from the dental silver or dental amalgam fillings that almost all people in the Western world have in their mouths. This mercury from the fillings is released from the fillings by mechanical wear, such as chewing, by evaporation, and by dissolution. And moreover, when you go to the dental office to have fillings drilled out or replaced, significant amounts of mercury can be released at the time of the removal of old fillings. So consequently, the dental amalgam represents a chronic low-dose exposure to a toxic heavy metal. A metal, like I've said before, which is more toxic than lead or arsenic. And I find it quite curious that we consider it important to take lead out of gasoline while we allow the dental profession to continue to place a material that's even more toxic into our very teeth inside our bodies. So there's a debate going on. The debate is between dentists and dentists. One group, the so-called establishment, the American Dental Association, the Canadian Dental Association, claims that these amalgams are safe and effective. They have claimed up until recently, without evidence to support their position, that the mercury was locked in, that once it was covered with saliva, the filling was stable and inert, and that the toxic property of the mercury was made harmless by this process. Of course, that kind of situation was not based upon scientific evidence, and indeed violates the basic principles of chemistry and of physics. So one has to ask, what is the evidence that dental amalgams are indeed stable? Are they stable? Well, early in the mid-1980s, we did some experiments that were published in the Journal of Dental Research where we looked at people with and without dental amalgams before and after chewing, and we measured mercury in their mouths to see what the level of mercury vapor might be due to chewing function. And this graph illustrates that on the x-axis is time in minutes, and on the y-axis is the concentration of mercury found in air taken from within an open mouth. At time 0, we have readings before chewing. And individuals with fillings in their mouths were giving gum to chew, and every 5 minutes the gum was spit out, another intraoral vapor test was taken, and a new fresh piece of gum was given, and they continued on. And what we find is that those subjects with 12 or more biting surface fillings showed a rapid rise followed by a plateau in the concentration of mercury in their mouths. And even when they stopped chewing a half hour later, it took another 90 minutes for the mercury vapor release to get back down to baseline readings. Individuals with 4 or fewer biting surface amalgams showed the same phenomenon, but to a lower degree, and those subjects with no amalgams obviously showed no significant level of mercury in their intraoral air. Well, this type of research has been replicated numerous times by various institutions around the world, and basically this scientific evidence points to the fact that the dental proposition that the mercury is locked in and doesn't come out once covered with saliva, that proposition is false. The evidence does not support that proposition. So up until about 1970, 1980, the dental profession was laboring under faith, under a belief that the material was locked in and harmless. Other evidence for this type of situation is the fact that in the United States and in Scandinavia, studies have been done on people who have died accidentally. And these studies looked at tissues such as brain tissue and kidney tissue and measured the level of mercury found in these tissues. These studies demonstrated that those subjects that had dental amalgams in their mouths had significantly higher levels of mercury in their brain and kidney tissue as compared to people who did not have dental amalgams in their mouth. Moreover, the greater the number of amalgams in the mouth, the higher the concentration or level of mercury found in the brain and in the kidney. So this again is evidence that in humans that the mercury not only leaves the fillings but appears to be able to migrate into the body and get into human tissues. Of course, none of this addresses some of the other important issues, such as, is the mercury doing harm? But we'll look at some of that data in a moment. In 1989, the World Health Organization brought together 15 experts from around the world to review the available scientific information on mercury in the environment. And one of the aspects that they investigated was dental amalgam. This particular body published its paper in 1991 and concluded that the largest single source of mercury exposure of all forms to the general population is mercury from dental silver fillings. Indeed, as this chart shows, dental amalgam contributes on average to the average person somewhere between 3 to 17 micrograms of mercury a day. Now, some individuals on the high end could be as much as 10 times higher than this range. So this is the average range. And all other sources of mercury, including seafood and fish, other foods, water, and air, all of them combined only amount to approximately 2.6 micrograms of mercury per day. Consequently, it's obvious from this chart that dental amalgam gives approximately a 5-fold increase in the amount of mercury than all other sources. Again, this does not address the issue of toxicity, but it does isolate the fact that dentistry is one of the last areas that uses such high levels of mercury in the treatment of human beings. The New England Journal of Medicine in 1991 published some interesting articles on the effect of mercury found in water-based latex paint. Because of this particular study that was published, mercury has now been removed from latex paints. You might ask, why was the mercury put in the paint in the first place? And the answer is very simple. Mercury is a fungicide and a bactericide. In other words, it's put in there to make sure that there's no bacterial or fungal growth in the water-based paint prior to placing it on the wall. The problem, of course, is that once the paint is placed on the wall, the mercury vaporizes out of the paint for a couple weeks into the room. And the longer you're in that room, obviously, the more mercury you'll take up. There were some case reports of young children who came down with certain signs and symptoms of mercury poisoning because of sleeping in bedrooms that had recently been painted. Indeed, in the article, a freshly painted room would give off vapor and a concentration of approximately 2 micrograms of mercury per cubic meter of air, which would translate into a daily dose absorbed for a person of about 4.6 micrograms of mercury per day. This is compared to what the average person would get from their dental amalgams on a daily basis, which would be approximately 10 micrograms a day. So as you can see, the dental amalgams for the average person gives you twice as much mercury on average than does the freshly painted room. One might ask the obvious question: if the mercury seems to be a problem in the paint and has been banned from usage, why haven't they banned it in dental fillings? If you're concerned about a mercury exposure that may last for only 2 weeks, why aren't we more concerned about an exposure that on a daily basis is twice as large and occurs for almost your entire lifetime? A good question, and obviously these are things that remain to be resolved politically. Other evidence that mercury from dental fillings is getting to places that it shouldn't, in other words, is not locked into the actual filling, is some work that we published from our laboratory at the University of Calgary Faculty of Medicine very recently in the FASB Journal. What we did is we took dental amalgam fillings and we added a very small tracer of radioactivity. Now, radioactive mercury does not occur naturally. It has to be made in a nuclear reactor. So consequently, if you find some radioactivity in the tissues of animals, then you know that the mercury had to come from the fillings. It's a very clean way to know exactly where the mercury is coming from. Well, we took an adult sheep, placed 12 or so mercury fillings with a little tag of radioactivity, and let the animal chew and eat and normally live its life for approximately 30 days, at which time a full body image scan was taken of the sheep to see if mercury could be seen visually in the various tissues. And as this picture demonstrates, and if you look carefully, you can see the outline of the sheep. As you can see, the mercury showed up in the jawbone of the sheep, denoted by this black area. It showed up in the kidneys of the sheep. It showed up in the liver and the gastrointestinal tract, as well as the transverse colon. In other words, it took only 30 days of chewing on fillings to demonstrate visually, in a very simple fashion, that the mercury migrated in significant levels from the teeth into the tissues of the adult sheep. Other studies have shown that in pregnant sheep, a similar phenomenon occurs, and the radioactive mercury leaves the fillings in the mother's teeth and will actually migrate into the fetus, which is developing. We could draw some clinical conclusions from this type of evidence, and that would be that pregnant women should not have any dentistry done during pregnancy, and perhaps even before or after pregnancy. Because one of the things we found is that in the sheep, after the birth of the lamb, significant levels of mercury could be found in mother's milk. And what's true in a sheep model is likely true to some degree in humans. So further research in this area is presently underway. As you can see from this particular picture, if you look real closely, you can even see that after 30 days you can visualize the kidney bean shape of the left kidney. And this area up here is the liver of the sheep. So indeed, mercury can be visualized from the dental fillings in tissues. However, a hue and cry came out from the American Dental Association and its advisors that sheep are not a good model, that they chew too much, that they regurgitate their food, and that they really bear no relationship to the human situation. So consequently, we approached the situation by replicating this research in monkey. And as you can see from this particular whole body image scan, and if you look carefully, you can see the arms here, and the head area here, the torso down here, and here are the legs. As you can see, the mercury collected again in the jawbone, collected in the kidneys, and collected in the gastrointestinal system. So what's true in sheep is true in monkey and must be true in human too to some extent. So we've proven up to this point several things. The mercury leaves the filling. It leaves the filling in significant quantities. Number two, in leaving the filling, it can enter tissues of the body and deposit in various tissues. Most significantly, it deposits in kidney and in the GI tract and in brain tissue. So we have to now address the issue of, is there any pathology because of this mercury? Or is this mercury so low as to be insignificant to cell health and to human health? Well, in order to address this particular issue, we again took our friend the sheep, and we placed some non-radioactive mercury fillings in the animal. But before we did that, we measured various functions within the animal. We then placed the fillings, and then at various time intervals after the placement of the fillings, we again examined the animal for physiological changes that might occur. And this particular graph shows the time after amalgam placement, and here's time 0 here, or when the amalgams were placed, and this is clearance of inulin. Clearance of inulin represents the ability of the kidney to act as a filter. And we had two groups of animals, one group that got dental amalgam, and another group that got non-mercury containing fillings called glass ionomer. And what you see here is that within 30 days after placement of the dental amalgams in the adult sheep, the sheep lost 50% of the clearance capacity of its kidneys. In other words, that's tantamount to losing one kidney. Now, would this make the sheep ill or sick or unable to live? Of course not. You and I probably know people who operate on one kidney. When it comes to kidneys, we seem to have more than enough. But the fact of the matter is that some pathological process did occur. Indeed, if you check the sheep again at 60 days, you can see that it's still down there and has not responded back up to the normal level. The animals that didn't have the mercury fillings, however, showed no significant change at 30 days from when the fillings were placed, when the non-mercury fillings were placed. Well, we went on to look at various parameters and various physiological indicators, and we found that the sheep with the amalgams showed a rise of sodium in their urine. Now, the kidney has as one of its main functions to reabsorb sodium, in other words, to conserve sodium. And what we see here is sodium loss, indicating that the mercury was affecting the kidney's ability not only to filter blood, but also to secondarily reabsorb sodium. Moreover, albumin levels showed a drop, and this is a reflection in perhaps a reduced renal blood flow to the kidney. So all in all, we've identified some pathophysiology with regards to the kidney in sheep. Does this particular phenomenon hold true in monkey and human? Well, research is presently underway to see if this particular phenomenon does show an effect in human and in monkey. But there is some indirect evidence in humans published by a Swedish research group. This particular group took 10 human subjects and looked at their blood mercury level and showed that the level of mercury in the blood correlated with the number of and total surface area of the silver fillings in their mouth of these individuals. In other words, the more fillings, the higher the mercury level in the blood. 12 months after the fillings were removed in the 10 subjects, there was a 50% drop in the mercury in the blood and a 25% drop in the mercury in the urine, indicating that the source of the mercury that was in the blood, having been removed, caused things to return to a lower level. But most interesting and most significant in this particular study is that by 12 months after the amalgams were removed, the urinary albumin level rose. In other words, in our sheep, when you place the fillings, the urinary albumin level dropped. And in humans, when you remove the fillings, the opposite occurred. The urinary albumin level rose, indicating that in the humans it's very likely that the mercury from the silver fillings was affecting kidney function. Again, what's true in animal models usually holds up to some extent in humans. And this is why the regulatory bodies such as the FDA base a lot of their decisions upon animal research, because things can be done in the animal model that cannot be done in humans. And this research into mercury has greater effects than just the human experience. Right now, the Brazilian rainforest and the Amazon River is polluted with mercury from gold mining in the Amazon. And what we learn today in these small experiments may to some extent go to protect our biosphere in terms of mercury pollution on a grand scale that's occurring in many areas in the third world. Mercury, in terms of pathology, has also been implicated but not proven in the Alzheimer's disease process. The University of Kentucky has several research groups that are actively looking at mercury and the relationship to Alzheimer's disease. In early work, they took subjects who died having Alzheimer's disease and compared the concentration of various metals in areas of their brains to subjects who died not having Alzheimer's disease. And after analyzing all the various metals, what they found is that the only metal that showed a significant difference was for mercury. And indeed, this mercury was isolated in the area of the brain where the Alzheimer's lesion is typically found. Now, the Alzheimer's lesion, when one looks at it histologically under a microscope, is tangles of the neurons. In other words, the neurons in the brain are not laid down in a nice, fine, proper network. They are all tangled and crossed over. And this particular group at the University of Kentucky concluded that the likely source of this mercury exposure was either from dental amalgams or seafood. Now, people in Kentucky, we are told, do not eat a lot of seafood, so it may be likely that the largest source of exposure to these people is their dental amalgam fillings. But their group so far has gone beyond this and has identified the fact that there's a pathway where this mercury seems to take effect. In the brain is a chemical called tubulin, which is responsible for laying down proper neurofibril networks. When this particular protein is interfered with, you get the tangles. And in animal experiments, where they fed one group mercury in their diet and another group aluminum in their diet, they showed that mercury, not aluminum, caused an irreversible block in the tubulin and consequently caused the neurofibril tangles. So we now have new evidence that perhaps mercury is related somehow to the Alzheimer's disease process. This particular group at the University of Kentucky has been funded by the United States government to investigate the potential relationship between dental silver fillings and Alzheimer's disease in humans. And we have right now an inkling of what may come. But as scientists, we have to wait until we finally see what the data shows. But in my mind, as a dentist and as a clinician, this raises reasonable doubt. It raises the potential of risk with regards to the safety of these fillings. Very recently, in 1992, the Society of Toxicology had an annual meeting in Seattle, Washington, and various scientists from around the world were at a special symposium as to the importance of mercury release from dental fillings. Two very interesting sessions that were discussed was some research from Sweden under the direction of Dr. Mats Berlin that showed that in monkeys and in rats exposed to low levels of mercury vapor, the kind of levels one might expect to get from their dental fillings, it showed that there was impairment of the fetal brain development, that there was high levels of mercury in the nucleus basalis, the same place where Alzheimer's disease is found, and premature birth and low birth weight in the offspring of the monkeys. In rats, it was demonstrated that there was impaired fetal brain development as well as a learning disability in the rats exposed to mercury while in the womb. Well, this raises some very serious issues with regards to dentistry and with regards to mercury exposure and the development of, of human embryos and human babies. In another interesting paper presented at this symposium, Dr. Rowland and his co-workers showed when they examined dental assistants that those dental assistants who prepared 30 or more dental silver fillings per week had a fertility rate of only 50% that of matched controls. This particular information is in stark contrast to that presented by the American Dental Association, which claims that there are no adverse effects to dental assistants and dental personnel due to the occupational exposure from dental amalgam mercury. So if one can sum up what's been going on, it appears that the mercury in the fillings migrates out, gets absorbed through the lungs, into the bloodstream, ends up in the kidneys, ends up in the liver. Some of it goes down the esophagus into the gastrointestinal system and apparently can do its thing in terms of changing normal physiology. Well, all this stands in stark contrast to where we started, doesn't it? We started indicating that the dental profession at large assumed for a long time that the mercury was locked in and its toxic properties were made harmless. Recently also, in the 1980s, a meeting was held in Washington, I believe, Washington, D.C., sponsored by the National Institute of Dental Research and the American Dental Association, and after supposedly reviewing the literature, they claimed that mercury is not a problem, except for a very small number of people, thought to be less than 1% of the population, who might be allergic to mercury, as opposed to toxic to mercury. Of course, allergy has to do with typically what one thinks of in terms of allergy, an immune system response. Well, what is the evidence that they have for this less than 1% hypothesis? Well, if you look at the dental literature itself, the scientific documentation published by dentists for the most part, you can see that there's a wide range. When one looked at dental personnel, that ranges anywhere from 2% to 39% hypersensitivity to a standard dermatological patch test. If one looks at the general population, one can see that anywhere between 5 and 26% of people react to a patch test. And if we look at patients that are suffering from oral lichen planus of the mouth, okay, one can see that between 16 to 62% of these people react. So where they came up with this less than 1% hypothesis is amazing to me. It just is not borne out by the scientific evidence. Indeed, the North American Contact Dermatitis Group, which is probably the watershed study, examined 1,200 individuals from various areas in North America and showed that 5.4% of the population responded to the patch test to mercury. And the prevalence of this response was much higher in whites than it was in blacks. There was no conclusion as to what could cause this. However, they concluded that even the lowest prevalence rate of 2% in the series that they studied indicates and justifies that this antigen be included in screening series. Yet most dermatologists do not test for mercury hypersensitivity anymore because the medical profession's assumption has been that mercury has been removed from most products for human consumption. Unbeknownst to medicine, dentistry for 150 years has been placing silver fillings in your mouth that contain 50% mercury. When going to test to see if you're having a high exposure to mercury from dental fillings, blood and urine tests have been shown to be of no diagnostic value because the mercury vapor does not stay in the blood or go to the urine, but rather migrates into the tissues. What we have here is a very unique situation. We have a chronic, low-dose exposure to a toxic material. One has time-released exposure to a very potent poison, and it doesn't hang around in your blood or go to your urine. It goes to your tissues where it accumulates and potentially has the possibility to do harm. So it's scientifically established that mercury is highly toxic to humans, especially inhaled mercury vapor and ingested methylmercury. There's no safe level below which exposure to mercury is considered safe. It's scientifically established that the prevalence of contact hypersensitivity to mercury is at least 5% in the North American population. It's established that blood and urinary levels of mercury are not diagnostic on an individual basis. They do correlate with symptomatology on a tissue level for populations. It's scientifically established that the placement and removal of dental amalgam or dental silver filling restorations, chewing, toothbrushing, and drinking hot fluids will exacerbate the mercury release from the amalgams in your mouth. Also, mercury release from fillings does not stop when the chewing stops, but the release of mercury continues for at least 90 minutes after you stop chewing. It's scientifically established that autopsies of humans showed that individuals with dental amalgams have higher brain and kidney levels than those without dental amalgams, and that dental amalgam mercury crosses the placenta to the developing fetus in animal models. It's scientifically established that radioactively tagged mercury from amalgam can be visualized by whole-body image scan in sheep and in monkey by only 30 days after placement of these fillings, as I've previously shown you, and that dental amalgam induces pathophysiology in the kidney and in the gastrointestinal system by altering normal bacteria, and has been implicated potentially in the Alzheimer's disease process. There are alternatives. Some of them have problems too, but what we have here is a situation of a material that is very toxic in comparison to the alternatives. So it behooves each of us to make some positive health choices. And there are many problems associated with the dental amalgam issue. First of all, the dental profession at large has no hard research evidence to support the safety of dental amalgam. It's merely been a theory that they've expounded for 150 years. There's probably legal liability to dental associations, universities, and companies that produce the product. Additionally, many dentists will need additional training to enhance their skills to use other materials. Dental insurance companies will only cover amalgam in many instances and will not pay for the use of alternative materials. And finally, the American Dental Association, in its great wisdom, has changed its code of ethics in 1987 to make the removal of amalgams from an individual an issue of malpractice. In stark contrast to how it started out 150 years ago, when the placement of dental amalgam restorations was considered to be unethical. So in summary, dental amalgam is the major source of mercury exposure. It vaporizes from your fillings, it's inhaled, crosses the lung, it's also swallowed, and it distributes into all the body tissues in animals and in humans, where it has the potential to alter cell function and consequently cause pathophysiology. Dr. Ralph Phillips, one of the leaders in dental materials research in the 20th century, has stated, ideally then, a dental material that is to be used in the oral cavity should be harmless to the pulp and soft tissues. Also, it should contain no toxic diffusing substances that can be absorbed into the circulatory system to cause a systemic toxic response. The material should be free from potential sensitizing agents that could lead to an allergic response. And finally, the material should have no carcinogenic potential. I would conclude that the available information on dental amalgam today, from a scientific perspective, shows that dental amalgam violates Dr. Phillips' definition of a safe dental material. And depending upon the dose and the frequency of exposure, even low levels of mercury exposure over the long term can produce pathology, which may take as long as 30 years to develop. So what we're looking at here is potentially a model that may run like this. As a child and as an adolescent, you get the fillings placed in your mouth. And if indeed dental amalgam is proven to produce human pathology, it may take up to 30 years. In other words, it may take to middle age before the pathology occurs. Dental silver fillings, they're your choice. I would recommend that you assess the available risks and make your own conclusions. It's your right to choose the materials that you want in your body. Consult your dentist.
Dr. David Kennedy is a national and international lecturer as well as a researcher. Presently, he is president of the International Academy of Oral Medicine and Toxicology.
When you're considering restoring teeth with biocompatible materials, there are a number of considerations that it's important for you to think about. An overview or a concept that many of us have adopted is that prevention is the only real way to solve the problem of toxic metals. Children can be raised today virtually tooth decay free with the advent of some of the bonded sealants that can be placed on the chewing surface of the back teeth. The back molars that come in when the child is 6, 12, and 18 years old have a groove in the center of it. That groove often is a source of decay. Those grooves can be sealed up very easily without any shots, without any discomfort for the child, but must be sealed before tooth decay begins in order to preserve all of the enamel structure. So sealants are the first recommendation I have for a family to raise the next generation free from the large holes that appeared in our teeth, my generation. Nutrition is important for raising kids free from tooth decay. You have to keep them away from refined carbohydrates. Encourage them to brush their teeth, sometimes with rewards. Some of the new mechanical toothbrushes are much more effective than doing it by hand. Discuss these things with your dentist. But first and foremost, let's stop the problem. Children should be raised with relatively few or no cavities. And then let's look at the adults. Life is a series of learning experiences, and what happened to me when I was a kid is that I was virtually cavity-free till I was 12 or 13, and then I began to develop some cavities in my back teeth. All in all, I ended up with about a dozen large fillings in my molars. That's the average American, a dozen large mercury fillings. When it came to my attention that I wanted to have those replaced, I began to look into alternatives. At the time, there were no really good posterior or back molar composites, but I selected what was on the market at that time, some 10 years ago, and tried it. They held up okay, 10 years, it's not bad, not good, but they did wear down. So wear was one of the principal problems with the older composites. Also, in the larger fillings where they would go down in between the teeth, an area could be light in contact. It would catch food if it wasn't properly restored. There are restorative problems with the composites that by and large can be solved by modifying the techniques. Dentists have for a number of years been studying how to use these materials better. One of the techniques that is now becoming quite popular is doing what are called indirect composite inlays by removing the old material from the tooth, taking an impression, having it made in the laboratory. You can harden the material, thus solving much of the wear problem, get the adequate shape, thus solving the contact or the flossing problem, and the third one is by allowing all of the shrinkage that takes place during setting to completely be processed out of the material. And fourth, the material is fully processed so that there are very few leftover reaction products in reducing the sensitivity from these materials. The inlay then is bonded into the tooth with a composite bonding cement. When a dentist selects a material to restore a tooth, if I'm the first dentist to fix a cavity, say for example the cavity is the size of the head of a pin, then a direct composite filling placed in that one pinhead sized cavity is ideal. If it's the size of the head of a match, it still probably can be restored with a direct composite. Once it grows beyond small and starts becoming a large cavity, then you need to begin to think of strengthened composites or a more durable material, a gold inlay or a porcelain. The problem with amalgam is that if you have a pinhead-sized cavity, the dentist has to make a shoebox size hole to get the filling in. The material is very thick, and the dentists are taught to remove approximately 1/3 of the center of the tooth. That's too much tooth removal. The only thing that we know for sure will last a lifetime is the enamel. Drilling 1/3 of it away to get a very thick material in a small cavity is not logical. Also, By drilling away the middle third of the tooth is weakened 75%. That in the result will result in the fracture of the tooth down the line and causing additional restorations. In addition, no restoration that we currently have will last a lifetime. None of them. They all have a finite life expectancy. So you need to think of the future. If you remove a large portion of the tooth today to put a restoration in, then there's going to be less and less tooth to fix in the future. If, for example, a filling lasts 7 years and a child is 7 years old, how many times can you fix that tooth in a lifetime? So conservative restorative materials, ones that remove very little tooth, 2 are durable and will hold up under chewing loads, are what we feel is the state of the art. Gold is a material that's been used for 100 years and more. Even the Egyptians had used gold to a certain degree in dentistry. But modern gold restorative materials are excellent as long as they don't contain other toxic metals. The problem with gold is that it's seldom pure. As a matter of fact, it cannot be pure and be used when it's fused to porcelain, because the melting point of gold is so low that before it fused to porcelain, you would have a puddle. So gold is always a mixture of something else. My recommendation is that you discuss the mixture of gold. What alloys are going to be used in the restoration of your teeth? One alloy used all the way around for every restoration, or all the metallic restorations, I might say, is a good idea. That way you don't have dissimilar metals in the same mouth. In the future, when you select materials for restoration, select ones that are considered biocompatible by today's standards. That means that when the cells or bacteria are subjected to these metals and materials and filling materials, that they don't react, they don't develop broken chromosomes. They basically can pass rigid biocompatibility tests. In the future, when you have restorative materials placed in your mouth, select ones that are attractive and yet strengthen the tooth, not weaken it. Bonding will adhese the sides of the tooth together, bringing the strength of the tooth back up closer to normal. How long that strengthening lasts, we don't know for sure, but we can demonstrate it certainly has a positive effect on the strengthening of the tooth. And that is bound to mean stronger teeth, a better looking smile, and fewer dental bills in the future. Prevention is, after all, the only way to go, because the best dentistry in the world is bound to fail without preventive dentistry. So with the help of your hygienist and your dentist, learn how to take care of the restorations. Clean your teeth down underneath the gums, around the edges. The most common reason for any dental restoration to fail, regardless of the cost, is recurrent decay. Decay is a problem of all Americans at one time or another. So learn to keep your teeth clean, especially down under the gums and in between the teeth. Use the high-tech mechanical tools and select biocompatible restorative materials.
Dr. James Mazzi is a national and international renowned lecturer and researcher in both electrical and biomedical research, along with oral kinetics and their potential consequences.
We're very willing to talk about mercury and the environment. Every time we happen to see something about fish having mercury, we don't really bat an eyelash when we say, gee, isn't that awful? We fail to look at the personal environment inside the oral environment. Before 1960, basically all of the diagnosis in the mouth and the measurements were in differences in potential between the oral metallic objects. Back in 1952 and 57, there was a lot of work going on this. And they started to look at the connection between biological reactions and oral galvanic activity. It seems as though some of that was lost in the process. 57, the oral biological phenomenon was a result of electricity. Really not so much of a phenomenon, but an effect from the man-made objects we were putting in the mouth. Things like amalgams, gold, silver, the components of amalgams, a variety of different things that we're putting into the mouth and expecting them all to sing harmoniously. It's just like saying that we have two metals in a light socket, and exposed to the weather, we expect them not to corrode, one corroding the other. Same thing in the mouth. So there was some work done before 1960. It seems as though the shift and the emphasis in the oral cavity went to looking at bacteria and a variety of other things, as opposed to really focusing on the galvanic effects. Amalgams were in their heyday. They are very strong materials, but they do have one very toxic element, over 50% mercury in it. As a result of some of the previous work that myself and other researchers have done, we've defined another area outside of the bacterial effects and the fluorides and nutrition and the oral hygiene that goes along with the tooth substance itself. We defined the bioengineering function. These factors actually are biomechanical, biochemical, and bioelectrical. What I'm focusing on today is the bioelectrical aspects. Bioelectrical aspects come from pressure type induced effects, where we have malocclusion or misalignment of teeth. Electrochemical, what we're talking about with the mismatched metals. Potential differences that occur in the mouth, or voltages across various parts of the mouth. And electrolysis, the actual movement of ions or the charged species of the metals in the mouth. This is what is called an electromotive chart, or an electrochemical chart, which shows from the bottom, the most corrodable, to the top, the least corrodable. Notice gold is up there and platinum. Down at the bottom here is magnesium, aluminum, and zinc. Well, right up here is silver and mercury, two of the main components. It says that anything above here will corrode the silver-mercury combination. Anything below there will be corroded by the silver-mercury composition. Well, it isn't really that simple, because silver and mercury are not the only two components in the amalgam. As a matter of fact, a lot of work was done in 1980 by Holland, when he said gold and amalgam placed in contact in the oral cavity will cause galvanic currents and the corrosion of the amalgam, releasing metal ions. It's not that we haven't heard this before. The electric currents and possibly also the release of metal ions may cause oral discomfort in certain individuals. So it's nothing new. People have looked at it and people have stated it. But it really isn't that simple. There are a number of phases or different compositions associated with the various materials, which are silver, tin, copper, and mercury. Gamma 1, gamma 2 phase. The gamma 2 phase used to be the most corrodable phase until we started with copper and tin additions, the copper additions especially. The gamma 2 phase no longer is there since we've added copper. Potentials of the phases look like this. We decided to separate them, and the research that we did pointed to the fact that we have gold, titanium, and 316 stainless steel, which is probably the main one used for appliances such as bridges and a variety of other things in the mouth. Silver is sitting here. The various phases are defined. Mercury is down here. So everything above mercury corrodes mercury. Everything below is corroded by mercury. This is a scanning electron microscope picture of a freshly polished amalgam. Notice the various phases that we have. Well, that's not so surprising. And then notice this little area that looks like it's sweating here. That's mercury droplets. That's coming right out and being squeezed out of what people call an alloy. It's an amalgam. It is not in the strict sense an alloy. You would not be able to squeeze another material out of an alloy. The mercury is free mercury. Once it hits that surface, it's free to evaporate into the oral environment. There are some interesting things that come about as a result of looking at this oral galvanism. The reality of the corrosion in mercury amalgams is there. We find amalgams that are partially corroded with the mercury gone. Where does it go? Well, matter is neither created nor destroyed, so it must go into the oral environment, in saliva. It then goes into the body system in combinations of both organic and inorganic. In other words, attached to a protein as methylmercury, or inorganic as chlorides and various other materials in the body. We took a look at something else, a bit of a surprise to us, but we decided to look at TENS, transcutaneous electroneural stimulation. This is very often used in patients who complain of TMJ, or temporomandibular joint discomfort or disease, or TMD as it's sometimes called. This temporomandibular joint has actually a region around the jaw here wherein we put two electrodes, apply a voltage to them, a voltage which, by the way, is fairly high, and in turn loosen up that muscle or tone the muscle sufficiently to be able to do what we have to do to help the discomfort associated with the temporomandibular joint disorder. In the process of that, we felt that very possibly we might be seeing some material into the region of the mouth as a result of the currents that flow from this temporomandibular joint TENS machine. Now, what we did was to take saliva specimens and run them through an atomic absorption spectroscopy machine, which allowed us to see how much mercury was in the saliva. As a result of this, we ran these are various coded numbers. Each of the people working on it, only one person knew the coded numbers. The people who did the atomic absorption did not know the code on them, and I didn't even know the code on them. My students did. We ran them for 15 and 30 seconds at each of the settings, ranging all the way from a low voltage up to a high voltage, with one or more mercury amalgam fillings in the mouth. The results were a little bit astonishing. We ended up with mercury that increased, of course, with the voltage and with the number of amalgams in the mouth. In fact, it increased to 32 parts per million at a maximum. As a result of this, we found that outside influences of electric fields do indeed dump more mercury into the system than what we ever thought before. Further work is going on this, but I think it's an area worth investigating. Not only the currents from without, but also the currents from within, due to the electrochemical effects. It's a very interesting field, and I think we ought to start getting back to some basics in science, and I think some of the establishment ought to start listening to what's out there in real science and start facing up to the fact that mercury in the mouth should never be allowed. These are the voltages, by the way, that we apply with the TENS. If you want to look at something else that may be shocking, it's the level of the voltages. Pardon the pun. I think that's about it. Just an awareness of the real science of material science in the mouth due to electrochemistry. Thanks.
Dr. Richard Fisher is a lecturer and clinical researcher, as well as on the professional faculty of the National Center of Homeopathy.
Controversy has surrounded the issue of fluoridation since it was first introduced into the United States in about 1945. The controversy really has centered around three different issues. One issue has been the infringement, as people perceive it, on their informed consent. In other words, does the government have a right to put mass medication into the water system? The second controversy has related to the safety of fluoride, and thirdly, the efficacy of fluoride. Regarding the first issue of the informed consent, my only opinion here is that I know of no precedent in this country for the mass medication for a disease, in this case dental decay, for which there is no, it is not a life-threatening disease, it is not debilitating, nor is it contagious. Regarding the efficacy, the proponents of fluoridation currently claim that the decrease in tooth decay that we get from fluoride amounts really to only 1/2 of a cavity statistically per child. When we get to looking at some of the current scientific literature that has come out in the past 4 or 5 years, the main epidemiological studies carried out in the United States, New Zealand, Canada, and Australia, all of these studies have shown that there is no difference in decrease of tooth decay in fluoridated versus unfluoridated areas. And it's also been shown in the literature over the past 50 years that the decrease in tooth decay actually predated the use of fluoride in the water or other therapeutic uses of fluoride. So there's certainly a great question on the original claims of 40% or 30% reduction in tooth decay. The claims now are more about 18%. And for the sake of argument, let's assume that that is correct and that the studies that show that there are no differences may be wrong, and that the proponents do indeed show correct that we do show a decrease in the decay rate amongst children. The issue of toxicity, I think, is the main one to consider here, and for the potential benefits of the reduction of 1/2 of a cavity per child in this country, I think the toxicity really makes this whole question rather moot. The signs and symptoms of fluoride toxicity, as you can see in the list here, are some of the signs of acute fluoride poisoning. Many of these are gastrointestinal type of symptoms, and it's believed generally that when you get a toxic dose of fluoride, the body reacts by vomiting and therefore purging the system. These were 34 cases of acute fatal fluoride poisoning, and you can see the different symptoms that occur. Besides the gastrointestinal problems, you will see some neurological and musculoskeletal symptoms. In contrast with the chronic fluorosis, you'll see a much higher incidence of musculoskeletal and neurological types of symptoms. The toxicity of fluoride is largely due to its chemical properties, and it has two unique properties. One is that it has a very strong ability to inhibit enzyme systems in the human body. There are an estimated 100 different enzyme systems that are very, very easily and dramatically inhibited by fluoride in very small concentrations. Many of them below the 1 part per million, which is added to the water. One example would be the enzyme systems that govern our neurological and musculoskeletal nerve firings. Those enzymes are cholinesterase and acetylase. Cholinesterase being the enzyme which causes acetylcholine to break up into its components, acetyl and choline, and acetylase is the enzyme that puts them back together to reform acetylcholine. These two enzymes, cholinesterase and acetylase, form this reaction back and forth at the rate of 300,000 times per second. Fluoride will inhibit this enzyme system down to a few parts per billion. And any interruption or inhibition in this system, for example, can lead to many sorts of neurological and musculoskeletal symptoms, such as found in Alzheimer's disease. Another concern that we have regarding Alzheimer's is that fluoride, when added to the water and boiled in an aluminum vessel, compared to water without 1 part per million fluoride, the fluoridated water will cause a 1,000-fold increase in the amount of aluminum leaching out into the vessel, into presumably the food or beverage that is being cooked. Aluminum is a well-known heavy metal poison and can accumulate in the central nervous system as any heavy metal. So we don't endorse certainly aluminum vessels to do cooking in, but if you're going to use them, don't cook with fluoridated water. Regarding other toxic effects of fluoride, certainly the two that we're most knowledgeable about probably are the dental effects, which is called mottling. Dental mottling in its earliest stages causes little chalky white areas to form on the enamel surfaces of teeth. As this problem gets more severe, these areas become brown, blackish, pitted, and the teeth become very brittle. Interestingly, today, the government, EPA, only recognizes this as a cosmetic effect and not as a health effect. While in reality, that's only a political observation, the scientific observation is that what has happened to cause these changes in the enamel is that abnormal collagen has been formed as a result of the fluoride inhibition on the enzyme systems, and that the mottling is actually a permanent scar on the tooth, showing that there has been the initial stages of poisoning to the system. If the tooth has been poisoned, certainly the bones have also been poisoned, which is the other area where fluoride is mainly concentrated. In the form of fluoride poisoning the bones, we initially will see stiffening of the joints, exostoses of the long bones of the arms, like you see here. Interestingly, the Environmental Protection Agency recognizes this simply as a cosmetic effect. This is not considered to be a health effect. The only time they recognize it as a health effect is when it gets to this third degree, which is called skeletal crippling fluorosis, which you see in this slide. Only at this level of toxicity will the government in this country allow this to be called a health effect. Using this factor only at the current water consumption standards, or at current water consumption levels, with the now allowed 4 parts per million in the water system, this disease, this arthritic condition, is estimated to be in store for probably over 100,000 children in this country that drink larger levels of, larger amounts of water per body weight than adults do. Other effects of fluoride are chromosomal damage, which has been found in human studies, animal studies, and in epidemiological studies. We have seen a 15% increase in the rates of Down syndrome in children born to women in fluoridated areas versus non-fluoridated areas. The estimates of daily intake of fluoride from 1943, which is before fluoridation occurred, which was about 1 part per million, to 1974 increased about 3 to 6-fold. The concentrations in soft tissues where you don't want fluoride has also in that roughly same period increased about 3 to 6-fold in the soft tissues of human beings. Other effects that have been shown at 1 part per million or less in the peer-reviewed literature are decreased human white cell migration, a 15 to 20% increase in tumor growth rates in mice, a 50% inhibition in DNA repair enzymes, and, as I mentioned before, chromosomal damage, which has been shown in animal studies in mice. At 5 milligrams per day, which is about the current estimated intake level, we know that fluoride at that level can produce skeletal fluorosis in humans, and it is enough to lower thyroid function in humans as well. Of course, dental toothpastes, to put it in perspective, contain about 1,200 parts per million fluoride as opposed to the 1 to 4 parts in the water. In conclusion, I would have to say, because there is no margin of safety between what is perceived to be the therapeutic dose and the toxic dose of fluoride, even using only the 3rd stage of skeletal fluorosis as the only politically recognized health effect from fluoride, that this lack of margin of safety is one that we really have to look at very strongly. When we consider the risks of the toxicity of fluoride versus the potential benefit of merely a half of a cavity less per child, I think, in my opinion, the risks greatly outweigh any potential benefits.
Dr. Paul Rubin is a general practitioner, past president of the Washington Society of Preventive Dentistry, as well as a lecturer and researcher.
Look at this question of the effect of mercury from dental amalgams on human health. We must also consider one avenue that's often been overlooked, and that is the effect of mercury from dental amalgams on the environment. There's some key questions that need to be looked at. How much mercury is actually used in dentistry? Where does that mercury go? Does it end up in the environment? Is it capable of entering the environment? And if so, by what route? And does it enter the environment in amounts that are significant enough to cause harm to the environment? And if so, what can we do about it? The Department of the Interior, in I believe 1985, estimated that about 5.6% of the total production of mercury in this country goes into the dental profession, the rest going to other industrial sources. That means that about 100 tons annually of mercury is going unregulated in use in dentistry. Unregulated because other industrial settings, the mercury consumption is very tightly regulated, but it's not in dentistry. So where does all this mercury go? Mercury that's consumed in the dental practice will go into a variety of different ways. Obviously, it's made into amalgam fillings. In this process, some of it will end up as scrap, sort of left over. This scrap may go into the trash. Hopefully not. Hopefully it will get recycled. Some of it will end up going into the discharge down the drain system. This new amalgam filling then is going to reside for a while in somebody's mouth. Eventually this filling is going to be drilled out and replaced as the filling fails with age, which they eventually will do. When this happens, again, more scrap amalgam is going to end up in sort of a sludge or slurry that goes down the drain and into the sewage system. There are other avenues for this amalgam from the filling. It may end up as an extracted tooth, which unfortunately may just simply end up in the waste. And amalgam in deceased persons will end up either buried or through cremation will again become volatilized into mercury vapor back into the atmosphere. There's another category that needs to go down here, and that is human waste. There's a significant amount of mercury through urinary and fecal waste that enters back into the environment. Just one aspect of this impact is on marine organisms. It is known that marine organisms are capable of undergoing a process called methylation, which changes mercury into an organic form of methyl mercury. This methyl mercury then is magnified or increased in concentration as it goes up the food chain. In recent years, about 26 states have issued health advisories or health warnings based on the increased amount of mercury found in fish and marine organisms in our lakes and in our waterways. According to the Clean Water Fund and Clean Water Action Group based in Washington, D.C., the primary cause of fish contamination in North America is mercury. Now, there have been some studies done to look at how much mercury actually is going into the waste stream of dental offices and therefore into the sewage systems. One was done in Arizona. One was done in 1991 in Seattle, Washington. There have been major concerns by the municipal organizations that are charged with handling waste and waste treatment systems as to what's going on with the mercury that ends up in the waste treatment plants. It must be understood that sewage treatment plants are not designed to handle toxic metals. They're designed to process human waste. So as mercury or other heavy metals enter the sewage systems and into the sewage treatment plants, some of it's going to go right on through into the so-called treated water. It's been estimated that maybe about 14% of the mercury that enters the treatment plants still goes through into the treated water. About 86% of it then ends up in the sewage sludge. This doesn't disappear. The sludge is then either buried in a landfill, it may be spread on land areas as fertilizer, or it may be incinerated. In any case, it is going back into the environment and likely back into waterways and water systems in the environment. The study done in Seattle concluded that, based on their findings, there should be developed and implemented a program requiring a significant reduction in the amount of waste discharged from dental offices. They felt that it should be required that there be a reduction in the amount of mercury discharged from the dental operatory waste stream, and to explore mechanisms such as filtration, settling, and centrifuging to control mercury entering the sewage system. Now, based on the data from this study and some other studies and some careful calculations with using available demographic data, some careful calculations have been done with some very interesting findings. If we look at this chart that summarizes, we're looking at dental mercury, that is mercury derived from dental amalgam sources that enters the environment through human waste, through dental office effluent, in other words, the waste stream from the dental office, scrap amalgam, etc. Note that crematoria contribute about 2,800 pounds of mercury a year into the atmosphere. If we look at the total of all of these, we have a staggering amount of 130,000 pounds of mercury per year entering the environment from dental sources. If we look at this over the last 15-year period, that's over 2 million pounds of mercury polluting the environment from dental sources. There does now exist technology to capture mercury from wastewater systems in the dental offices. This has been done for years in Sweden and Germany and other European countries. In fact, there are some rather strict regulations about dental office discharge of mercury in those countries. There are no such regulations yet in this country. So that's one part of the answer, to require a significant reduction of mercury discharge from dental offices. But the real full impact on this problem can really only come when we finally stop using this toxic material in dentistry.
Mr. Jess Clifford is a lecturer as well as the leading researcher and expert in the field of dental materials and its impact on the immune system.
Historically, one of the great concerns in dentistry has been that the materials that are being placed in the patient's mouth may not be particularly well suited to the individual patient. Traditionally, we have examined the parameters of strength, of durability, of aesthetic presence. We have worried about ductility and compressibility. We have looked at all kinds of parameters for dental materials. But always there is the nagging question, does this individual patient really get along with this particular dental restorative? Many traditional dentists don't worry about what's placed. It's assumed that whatever they choose to use as a dental restorative material will be workable for every patient. But increasingly now we are aware that not every material is well suited to every patient. In fact, we have found some materials that probably less than 5% of the population actually deal well with. In the basis of testing to assess whether a patient can get along with a particular material or not, we have found that many sensitizations that occur in the patient have nothing to do with their dentistry. In fact, we suspect that the majority of advanced problems will occur because of things the patient has had contact with from food, from water, from the environment, from their workplace, and they develop sensitizations that are later going to manifest as adverse reactions with the dental product once they are placed. We know that in these placements there are going to be a number of chemicals that will leach from the placement as soon as it is in place. We know that as these things sit in the oral cavity, as they come in contact with the acids, the fluids, the solutes, the other materials that are present in saliva and the oral environment, that they will begin to corrode and break down. It's readily obvious that even the most, quote, inert of the ceramic and porcelain products do slowly break down. And as these products corrode and give off their corrosion byproducts, it is those byproducts that become very toxic to many patients. For this reason, when a product is placed in a patient's mouth, we know that they do not always have immediate manifestations of their problem. Sometimes the involvement will be far removed from the mouth, and therefore a dentist is not likely to pay attention to digestive upsets, to cardiovascular problems, to neurologic symptoms, to dermatitis that occurs away from the head, and many problems from dental materials will be overlooked for this reason. In the testing protocol, as we developed this testing, it was immediately apparent that measuring toxic products was difficult at best and in many cases impossible with existing technology. We were mostly concerned with the ability to find those products that the patient adversely reacts with. Since those toxic products often are below detection limits of our instrumentation, We may miss them altogether if we simply do levels in the blood or levels of that material in the tissues. Secondly, even if we are able to measure some of these byproducts, what does it really mean? We have found, in fact, that some people may deal with a pound of something and do beautifully with it, whereas an ounce would flatten others. And so even the measuring of things that are potentially toxic does not necessarily guarantee that the patient will or will not tolerate those materials once placed in dental restoratives. And so as a model for testing, we determined that we would develop from a detection system using the immune system. We found that the immune system produces antibodies in the classes IgG, IgM, and IgA against those things that it has encountered that are toxic or noxious for the system. In testing, therefore, we don't ever really measure the level of toxic product that is present, but rather we look in a detection system to see if there are antibodies against chemical groups and classes and families of compounds. If we find that that is present, we know that this particular patient is going to have difficulty dealing with anything which can give off those toxic products once it begins to break down or corrode. With this in mind, we can then do immunologically based testing to see if antibodies are present. When we find them, we don't know how the patient got sensitized to the material. We simply know that they have reacted adversely with it, that there will be an immune response if it is presented again, and no matter where it started from, whether it was dentistry or elsewhere, the dentist knows that he does not want to place any new restorative in the mouth that can bring about an activity adverse to the patient with this substance. Therefore, from testing, we will first look to see those things that the patient has adversely reacted with based on the antibody record. Once we know what that record is, we will take that information back to the computer, to the database. We there know something about what the dental restorative compounds are made from. We know something about what's going to happen when they break down. We know something about their expected corrosion byproducts. We will match the patient's reactive data against that database of products. And once that has been done, then we can, with reasonable reliability, say to the doctor, products A, B, and C are not well suited to this patient because of the things they contain and what they will give off when they break down. Products X, Y, and Z show no adverse reactivity in this patient and should be the safest to use. We cannot guarantee that a patient will not become sensitized to something new in the future. I can say, however, from our research and clinical testing work, that once we reach past the years of puberty, approximately 12 to 14 years of age, most of us have been exposed to most of the things we are going to be exposed to. In this regard, then, reactivity testing will have a reasonable level of reliability and a reasonable level of accuracy, of reproducibility. We can say to the doctor, products X, Y, and Z will be the safest to use if you test this patient. And with a good level of reliability, the doctor can feel comfortable in the things that he will place in this patient. The advantages to the patient are obvious. First, they're not likely to have to come back to have this job redone. Secondly, we find that the patient is going to undergo a lot less discomfort. The symptoms and the problems that develop elsewhere in the body will be fewer. For the professional that is doing the placement, it means that the patient is only going to have to be in the chair one time for this particular job to be done. It means that you can place materials knowing that you are truly improving the quality of life for this patient. And thirdly, in the area of due diligence that exists in the profession today, it means that you have literally done all you can reasonably be expected to do to ensure that the best job has been provided for this patient and that you have done all that is reasonably expected of any professional. In summary, reactivity testing does not tell you that you should remove something from the mouth.
It does not tell you that the patient cannot have new reactivities, but with good reliability, it does say that if you are able to test this patient and then select from the materials that are not contraindicated by existing sensitivity, that this patient should have a good restoration, that the materials should be serviceable for a good length of time, and that you can be very pleased and proud of the work that will have been accomplished.
Dr. Michael Ziff is a national and international lecturer. He is also the author of The Missing Link and the co-author of Infertility and Birth Defects.
In order for a dental filling material to present a systemic risk to the health of a patient, 4 criteria must be satisfied. 1, the material must contain a toxic element. 2, that element must exit the restoration. 3, it must enter the body. And 4, it must reach harmful levels within the body. In the case of mercury exposure from dental amalgam fillings, all 4 of these criteria have been scientifically established. In 1984, the National Institute of Dental Research and the American Dental Association publicly acknowledged that patients are chronically exposed to mercury from dental amalgam fillings, primarily when chewing, when brushing, or when exposed to heat. The World Health Organization Expert Toxicology Committee determined in 1991 that the amount of mercury the average person gets from the amalgam fillings is 3 to 17 micrograms per day, which on an average is 3 to 4 times the amount that they receive from dietary exposure as from the consumption of fish. This same group of expert mercury toxicologists for the World Health Organization determined that no amount of exposure to mercury vapor can be considered totally harmless. This conclusion had been reached by mercury toxicologists for the United States Environmental Protection Agency in 1973 and reaffirmed it in 1984. So, scientifically, it has been established that dental amalgam contains the highly toxic mercury, that the mercury is not locked into the amalgam, that patients are indeed chronically exposed to mercury from the amalgam, that the mercury from the amalgam does build up in the body with time, and that there is no toxic threshold for mercury vapor. The only thing remaining now is research investigation determining just what health effects do result from this chronic exposure to mercury. Researchers in medical schools and medical centers throughout the world have already begun these investigations. First and foremost, studies were conducted tracing the mercury from dental amalgam into the body tissues. In addition to the body tissues of adults, it has already been established scientifically and found that mercury from the amalgams in pregnant females does transfer past the placental membrane into the tissues of unborn babies. Furthermore, it has also been shown that the mercury from the mother's amalgam fillings accumulates in the milk, so that when babies, newborn babies, are nursed, they get even higher amounts of mercury from the fillings of their mothers. There are areas of pathology that have been investigated and have shown a connection to mercury exposure from dental amalgam fillings. These include damage to the kidneys, to the bacteria in the gastrointestinal tract, resulting in an increased resistance to antibiotic therapy. It has also been demonstrated that mercury from dental amalgam damages the structures surrounding the teeth in the mouth, namely the gums and the bone. It also has been connected to the occurrence of a condition called lichen planus, which is an allergic condition. And there are also a number of clinical case histories being published and some epidemiological studies. These are the areas where pathology from mercury exposure to dental amalgam have already been established. There are other areas that are being investigated directly with dental amalgam where mercury has been shown to have a connection, and these include Alzheimer's disease, Parkinson's disease, multiple sclerosis, Epstein-Barr virus, and cardiovascular diseases. Given the scientific background, then, we compare this to the position of the dental profession, most directly the American Dental Association. These quotes are taken directly from ADA pamphlet number W186, which the American Dental Association presented in 1985. The pamphlet is entitled, "Dental Amalgam, Filling Dental Health Care Needs." The pamphlet states that scientific studies of dental amalgam in tooth restoration have been carefully conducted for more than 100 years. There is no scientifically sound evidence linking amalgam restorations to any general medical disorder. Quite the contrary, amalgam restorations continue to be shown safe for the vast majority of dental patients. The pamphlet then goes on to say, 150 years of experience with dental amalgam have proved it to be safe, an essential means of filling patients' health care needs. Now, what's interesting here is that between 1985 and 1990, the position of the American Dental Association regarding dental amalgam substantially changed. All talk, all discussion of scientific studies proving the safety of dental amalgam have been totally dropped. This is the position of the American Dental Association regarding dental amalgam as printed in the Journal of American Dental Association in April of 1990, entitled A Statement of Confidence in Amalgam. Quote, "The strongest and most convincing support we have for the safety of dental amalgam is the fact that each year more than 100 million amalgam fillings are placed in the United States, and since amalgam has been used for more than 150 years, literally billions of amalgam fillings have been successfully used to restore decayed teeth." Now, all discussion, all claims of any scientific evidence has been totally dropped, which leads us then to the formal position of the American Dental Association regarding dental amalgam. In 1986, the chairman of the American Dental Association's Council on Dental Materials, Instruments, and Equipment wrote this: "There appears to be confusion regarding both the role of the Council and the scope of ANSI ADA specification number 1 for alloy for dental amalgam. The specification is not for dental amalgam. It is only for the alloy for dental amalgam. The amalgam does not form until the dentist mixes the alloy with mercury. Therefore, dental amalgam per se cannot be certified. We cannot certify a reaction product made by the dentist." Now, this statement from the American Dental Association was very dramatic. First of all, the chairman of the council states that the ADA cannot certify a reaction product, but the ADA does certify dental composites, dental cements, dental impression materials, which are all reaction products. The chairman of the council goes on to say that the responsibility for the use of amalgam is not with the ADA, it's with the practicing dentists. The impression has been left is with the dental profession and the public that the ADA does approve the use of this material, and here in writing they state that they don't, that it's a dentist's responsibility. Well, upon investigation of the documents of the ADA on their specifications, this statement is true. The ADA does not certify mixed dental amalgam. It has ADA ANSI specification number 1, which is for the alloy for dental amalgam, and ANSI ADA specification number 6, which is for dental mercury. Neither one of these documents has any requirement whatsoever for biocompatibility testing. They simply address the purity of the product, the mixture, and the labeling, and that is all. Nothing to do with the biocompatibility or health effects of the materials whatsoever. However, the ADA does indeed have a document on mixed dental amalgam, and that document was prepared by the very same Council on Dental Materials, Instruments, and Equipment. And it is entitled The Recommendations in Dental Mercury Hygiene. This was published in the Journal of American Dental Association in October of 1984, and it states in this document that all amalgam scraps should be salvaged and stored in a tightly closed container. The scrap should be covered by a sulfide solution such as X-ray or photographic fixer solution. A no-touch technique of handling amalgam should be used. Direct contact or handling of mercury, amalgam, or other mercury-containing material should be avoided. And it goes on with several other recommendations. Clearly, this document determines that mixed dental amalgam is a toxic hazard. Now, the ADA has stated that they have no responsibility for the use of dental amalgam or any authority to regulate its use, and that this responsibility rests with a government organization such as the Food and Drug Administration. In 1976, the President of the United States signed into law the Medical Device Amendments of 1976. This legislation amends the Federal Food, Drug, and Cosmetic Act by adding new sections 513 through 521 to the code, which provides the FDA with significant new authority to assure the safety and effectiveness of medical devices intended for human use. The Food and Drug Administration prepared rules and regulations for the certification and approval of medical devices. And these were published in the Federal Register and state that the Medical Device Amendment of 1976 requires the FDA to classify all medical devices intended for human use, and that these must be classified into one of three categories. For devices where there is sufficient information to know that there is no health risk to the patient, these devices would be placed in Class 1, which is called general controls. There is no documentation required for these devices, and only the general controls of the manufacturer for the purity of the product and the labeling are necessary. The next category is Class 2, which is called performance standards. These are for devices where general controls alone would not be sufficient to provide a reasonable assurance of safety and effectiveness. Then the final category is Class 3, which is entitled pre-market approval. These are for devices where there is insufficient information to establish a performance standard, or which present a potentially unreasonable risk of illness or injury. Now, the Dental Device Panel in 1980 recommended that the FDA accept the classification of amalgam alloy as being safe and effective as a dental device, and that the alloy should be placed in Class 2, requiring performance standards. The Dental Device Panel for the FDA stated that the reason they recommended it be placed in Class 2 is that the material used in the device that contact the body should meet a generally accepted and satisfactory level of tissue compatibility. The panel believes that general controls alone would not provide sufficient control over this characteristic, and the panel went on to list the risks to the health of the device, which would be an adverse gastric or respiratory response or an adverse tissue reaction. Now, to be in Class 2, the FDA rules require that there be documentation establishing the performance of the device so that it would not present a health risk to patients. The Dental Device Panel, instead of providing documentation, had this to say in the summary of data on which the recommendation is based. Quote, The panel based its recommendation on the members' personal knowledge of and clinical experience with the device in the practice of dentistry. No data whatsoever. So the panel ruled that not only is amalgam alloy safe as a dental device in itself, but it's also effective as a dental device. No dentist would ever use amalgam alloy as a dental device. It won't stay in the cavity preparation whatsoever. At the same time, in 1980, the dental device panel recommended FDA accept dental mercury as a dental device that is both safe and effective, and recommended that it be placed also into Class 2, requiring performance standards. The summary of the reasons for the recommendation of placement into Class 2 was this: dental mercury is a toxic substance and must be handled properly to control the hazards it presents. The panel believes that general controls alone would not provide sufficient control over this characteristic. The panel went on to list the risks to health as being mercury poisoning and adverse tissue reaction. The panel based its recommendation on the panel members' personal knowledge of and clinical experience with the device in the practice of dentistry, and on one article published in the Journal of American Dental Association entitled An Environmental Study of Mercury Contamination in Dental Offices, which has nothing to do with the effects of dental mercury exposure in the patient. In 1987, the dental device panel then presented its final rules for the classification of dental devices and accepted amalgam alloy into Class 2 as it had recommended in 1980, and accepted dental mercury but moved it into Class 1, meaning the dental device panel ruled that dental mercury is non-toxic and presents no health risk to patients, even though in 1980 they had said that it presented the potential risk of mercury toxicity. In 1991, the Food and Drug Administration convened a panel to reevaluate dental amalgam and concluded that further research was needed to establish whether or not dental amalgam presented a health risk or not. At that time, the Food and Drug Administration placed into writing that it does not certify mixed dental amalgam. It has not evaluated it, does not classify it, and that the responsibility belongs to the dentist. So, it is clear from the documentation, all published in the Federal Register, that that dental amalgam is not an FDA classified device, which raises some interesting questions. Can dentists be legally punished for removing a device that has no official sanction? And point number 2, can dentists place dental amalgam with legal protection even though it has never been classified or accepted by the Food and Drug Administration? It should be pointed out also that the Occupational Safety and Health Administration has determined that mixed dental amalgam is a toxic waste disposal hazard and must be disposed of according to the material safety data sheets. The U.S. EPA has also determined that dental amalgam is a hazard to the environment and has already punished dentists for contaminating the environment with mercury from dental amalgam. So, dental amalgam has been declared a toxic hazard before being placed in human teeth and after being removed from human teeth by the American Dental Association, in the dental office by OSHA, and in the environment by the U.S. EPA. And the device as dental amalgam has never been approved or certified or classified by either the American Dental Association or the Food and Drug Administration, which means then that the situation in the United States is just as it is in Sweden, where the Supreme Court ruled that it is the individual dentist who bears the responsibility for dental amalgam, not the government or the Dental Association.
Dr. Philip Sukel is a general practitioner, lecturer, and clinical researcher. He is presently chairman of the Standards of Care Committee for the International Academy of Oral Medicine and Toxicology.
The International Academy, in light of the scientific literature you have already reviewed and have seen, has seen fit to establish a Standards of Care Committee. Within that Standards of Care Committee, there are two subcommittees, one being protocol and the other one preferred procedures. The Protocol Committee is based solely on scientific evidence. It reviews techniques, procedures, equipment, and even publications. And it can review things both in the medical community and the dental community. The Preferred Procedure Subcommittee approval is not based on a scientific evidence, but it also can be techniques, procedures, equipment, and publications, and can be both medical and dental in nature. The mercury vapor risk factor analysis is a protocol that has been approved by the International Academy. The purpose of the risk factor analysis is to determine the possible risk a patient may have to toxicity from vapors coming off of their dental amalgams. This is very important because it does not tell us whether or not you are actually toxic, but tells you what your risk is. It gives the patient an idea as to whether or not they should do something about the amalgam fillings. Another protocol is megadose of oral vitamin C. Oral vitamin C is a premier free radical scavenger. It protects against the effects of mercury released during the routine removal of mercury dental amalgams. Another protocol established by the International Academy of Oral Medicine Toxicology is the Clifford Material Reactivity Test. The purpose of this test is to assist in the selection of dental materials for new application which will be least offensive to the patient. When we get to preferred procedures, mercury vapor exposure and reducing it during hygiene or prophylactic procedures. When a patient has their teeth cleaned, those amalgams are stimulated either by the prophylactic cup or by the salt water when the stain is being taken off, or even by the ultrasonic scaler. During that release of mercury vapor, we want to protect the patient so that they don't inhale those vapors. We also want to protect the hygienist so she doesn't become contaminated with those particular vapors. Some of the techniques during hygiene procedures is to avoid touching those amalgam fillings with the cup and polishing brush, to avoid touching the amalgam fillings with the ultrasonic scaler, avoid direct spray of air baking soda on the amalgams, avoid polishing the amalgam filling itself. The research has shown that you bring mercury right to the surface when you're polishing those amalgams. You also would want to consider sources of air, either in the form of an oxygen mask or even room air with a mask connected so you pick up the air from another area not directly related to the mouth. You'd want to use high volume evacuation and a saliva ejector, even though a lot of times the hygienist is working all by herself. The evacuator itself, the high volume evacuator that the dentist would use, can be held by the patient near their mouth so these vapors are pulled off into the evacuation system. The doctor, hygienist, and staff should wear a protective mask, and the patient should wear appropriate protection such as glasses and bibs, etc. We also are concerned with the reducing mercury vapor exposure for the doctor and staff during removal. This is particularly critical in that even though we're being exposed to it, we want to minimize that exposure so that we don't become toxic to that mercury that we're trying to save the patient from. Amongst the techniques that we use are taking the amalgam out in large pieces, using the high-speed evacuation with even a double pump to pull that mercury vapor out as quickly as possible, and also chunking that mercury in as large pieces as possible. We also are concerned with reducing mercury vapor exposure for the patient during amalgam removal. There are two different ways that dentists work, and there are pros and cons to both techniques. Some patients have heard about the rubber dam as being the only way to put fillings in, but there are successful dentists that do very, very good quality fillings both with a rubber dam and without a rubber dam. It is pretty much up to the preference of the dentist which way he does it. But whichever way is done, some of the same techniques that protect the patient are the same ones that are used to protect the doctor and the staff. We're concerned about some nutritional areas. We're concerned about the evacuation of the vapors as rapidly as we can, about minimizing the amount of splatter on the patient, about cleaning the patient up as soon as those amalgams are removed before you go ahead and proceed to additional procedures as far as the actual filling of the tooth or crowning of the tooth afterwards. That pretty much concludes the standards of care area of the International Academy of Oral Medicine Toxicology. As time goes by, more standards of care are going to be developed. We hope that this is some help in guiding you, the patient, and informing other doctors and staff personnel as to what should be done.
At present, the IAOMT has chapters in Germany, Sweden, Brazil, as well as a U.S.-Canadian chapter. Chapters also are being formed in Taiwan and Australia. Through the Academy's Standards of Care, Research, Scientific, and Education Committees, the Academy hopes to be able to perpetuate our goals and disseminate information necessary for the good of the public, as well as educating the medical and dental profession.
For more information, the public is asked to contact their healthcare provider and/or the Foundation for Toxic-Free Dentistry at P.O. Box 608010, Orlando, Florida 32860-8010. Information can also be obtained by contacting DAMS, a national patient support organization, at DAMS Incorporated, 725-9 Tramway Lane Northeast, Albuquerque, New Mexico, 87122. Members of the medical and dental community are encouraged to contact the International Academy of Oral Medicine and Toxicology for information. For those interested in speakers on these topics, they may contact any member of the International Academy of Oral Medicine and Toxicology for information.